Okay, our next presenter. So thank you for coming back from break. So we'll go ahead and get started. We are now delighted to introduce our next presenter, Dr. Muthuswamy, Public Health Analyst in the Program Implementation Branch, Division of Diabetes Translation. She'll be sharing valuable insights with us on CDC's National Diabetes Prevention Program. So let's give him our full attention as we delve into this information presentation.
Where is that presenter?
I should be sitting at the other table.
Hi, everyone. Can you hear me okay?
We can, thank you.
Thank you. My name is Kavitha Muthuswamy, and I'm a public health analyst with the Division of Diabetes Translation in CDC's National Center for Chronic Disease Prevention and Health Promotion. And I'm joined today by my colleague, Beth Ely, who's a senior analyst with the National Diabetes Prevention Program. And first and foremost, good afternoon, honorable committee members and colleagues. I apologize for not being with you in person as I had planned, and I thank you for the privilege of presenting to the honorable committee members, CDC colleagues, and participants. During our time together today, during this hour, we'll provide a brief overview of the National Diabetes Prevention Program, also referenced as the National DPP. And then we'll move to the 2024 update to the CDC Diabetes Prevention Recognition Program Standards and Operating Procedures, or the DPRP standards for short. As you know, at CDC, we have a lot of acronyms. And we'll also share current activities to meet the needs of Native communities in implementing the National DPP lifestyle change programs. And so I don't know if the slides are up. Actually, we can go back to the title slide. Thank you. So before we start, I wanted to thank Dr. Kilsbeck, Ms. Coleman, and CDC colleagues, and also the tech team for making this virtual presentation smooth. I really appreciate that. But most importantly, I would really like to express our deepest gratitude to all of our tribal partners who we've had the privilege to work with, and their commitment to their communities, their candid feedback, and expert guidance. This is really the engine for our work. Next slide. First, we wanted to start by honoring the deep history of diabetes prevention programs across tribes and tribal communities and American, Indian, and Alaska Native populations. The invaluable contributions of Native communities and the success of the Indian Health Service Special Diabetes Program for Indians have been the foundation and shared history with the CDC National DPP. As you can see, here are some of the examples of that history and that work. Next slide, please. We just wanted to share a really brief overview of this shared timeline. As you can see, like in 1997, and I'm sure this is really familiar to many of you, but just a quick overview. In 1997, the Balanced Budget Amendment establishing the SDPI, the Special Diabetes Program for Indians. And in 2002, the landmark DPP study confirming that type 2 diabetes can be prevented. In 2004, we saw the SDPI-DP was authorized by Congress, followed by, years later in 2010, congressional authorization of the National DPP at CDC. In 2012, just 2 years later, the CDC Diabetes Prevention Recognition Program, or also the DPRP, was launched. And just very briefly, over the last 10 years, we've had the Good Health and Wellness in Indian Country Cooperative Agreement, working with tribes, which the Division of Diabetes Translation shares in, as well as the pilot program from the Choctaw Nation of Oklahoma to expand access to the National DPP Lifestyle Change Program, across different tribes that they served. In 2021 and 2022, CDC expanded a preliminary status in the DPRP that we talked about to SDPI programs, to include SDPI programs who had participated in SDPI and who currently do. And we'll talk about that a little bit later. And so currently we have a total of 73 CDC recognized tribal programs. I also wanted to just our overview, our work in the Division of Diabetes Translation is really driven by and committed to our federal trust responsibility in serving tribal communities. We're committed to listening and learning and using that to direct our work. We've heard from partners the need for support that fits tribal communities and tribal programs. As all of us here today really know, a goal of health equity isn't just to offer more of the same thing to everyone, but rather the right thing so everyone can achieve wellness. And that's our goal for the work that we're going to review today and our work together. Next slide. Thank you. We'll go just have a brief overview of the National Diabetes Prevention Program. It's a partnership of public and private organizations working collectively to build a nationwide delivery system for an evidence-based lifestyle change program for adults with high risk for type 2 diabetes to prevent or delay the onset. The National DPP Lifestyle Change Program is founded on the science of the Diabetes Prevention Program, DPP, the research study and subsequent translation studies, which showed that making modest behavior changes helped people with prediabetes lose 5 to 7% of their body weight and reduce their risk of developing type 2 diabetes by 58%. Next slide. At a population level, the national DPP has 4 overarching strategic goals: increasing the supply of quality programs across the US, increasing awareness and demand for the program among adults at increased risk for diabetes, increasing referrals from healthcare providers. Even though a referral is not required for the program, we know that it helps increase participant enrollment. And an increase for the public and private health benefit coverage for the program to ensure long-term sustainability of the program. All of these are really critical, and our work has to occur in all 4 areas. And for us in the division, we recognize that we also need to work in partnership with the programs that are already working, not just SDPI, but other programs that are working in tribal communities to prevent diabetes. But the tribes are not unfamiliar with this and have been doing this incredible work for decades, and working with those programs is really key. And we'll cover in this presentation our ongoing activities to tailor these goals for tribal communities and programs. Next slide. Thank you. The CDC Diabetes Prevention Recognition Program, or the DPRP, as we stated earlier, it plays a key role in ensuring quality across the many diverse organizations that are delivering the program across the country. The DPRP awards 3 levels of recognition: pending, preliminary, and full. And this is awarded to program delivery organizations that are able to meet the national quality standards. And these standards are updated every 3 years, both to stay in alignment with the science of type 2 diabetes prevention and to respond to the lessons learned from the field and through the analysis of program data. The DPRP plays an important function in collecting and analyzing the data across the organizations offering the program. Each organization gets feedback on their data and whether they are on course to achieve recognition and the support that they need. If they're not, we really are committed to offering technical assistance to identify the problem areas and troubleshoot challenges in the program delivery. We also maintain an online registry of all the programs in the US that's really maintained in real time. So, people can go and find a program near them, that they can, a CDC recognized program near them to attend or take, participate in a lifestyle change program. And it can also serve as a referral base. And again, this is really, we tried to update this in real time. Thank you. Next slide. There are many benefits to having recognition, and these include quality, which is linked to national quality standards, which we'll discuss here in a minute, and outcomes proven to prevent or delay the onset of type 2 diabetes. Data, it enables CDC to monitor progress individually and by program and across the nation, and therefore provide tailored technical assistance and support, and also to really inform the work that we're doing in our team to help meet the needs of programs that are serving tribes or American Indian, Alaska Native participants. Sustainability and reimbursement is also a big and evolving aspect to this. Many private and public payers are reimbursing for the program and are requiring CDC recognition because of those set standards. And this is something that we're really trying to expand, and especially in trying to delve deeper into those systems as for tribes and also urban Indian organizations, and how those reimbursement mechanisms work. Support, the recognized programs have access to technical assistance, training, and resources that's on our customer support center. Marketing also is, being a recognized program is an effective marketing tool to encourage referrals as well. Next slide. As mentioned, the DPRP assures the quality of recognized organizations, and to ensure quality and impact, CDC sets the standards for organizations that wish to offer the National DPP Lifestyle Change Program. These standards, the Diabetes Prevention Recognition Program standards and operative procedures, or the DPRP standards for short, again, another acronym, as we mentioned before, they're updated every 3 years. They're informed by the latest evidence regarding the science of diabetes prevention, DPRP data, and feedback from partners. And this is really the important part that we really want to emphasize today. And it has to go through formal Office of Management and Budget OMB posting to allow for public comment. Next slide. We wanted to highlight one of the main topics we wanted to discuss today were the key updates to the 2024 standards. So we're in this 3-year, the next 3-year cycle of updates. And so we wanted to discuss that with committee members and colleagues here today. So some of the highlights and key updates to the 2024 standards, to kind of synthesize that for our presentation today from organizations. The organization zip code is used to fast track organizations to preliminary status. As we mentioned before, it was preliminary, pending preliminary and full recognition. So fast tracking organizations to the preliminary recognition status for organizations that are serving populations in areas of the country that are identified as having a high social vulnerability based on the Social Vulnerability Index. But for tribal programs, there's, again, we had talked about the expansion of recognition status for SDPI programs. So in 2021, and then it was amended again in 2022, in response to requests from tribal leaders and acknowledging the expertise of SDPI programs and the success of SDPI programs. This CDC expansion included any SDPI affiliated program interested in implementing the National DPP program to automatically be granted preliminary recognition, so skipping over the pending recognition when they apply for application to the DPRP, the recognition program. And also any SDPI affiliated program currently under pending status during that time when that provision was, that expansion provision was finalized, were automatically advanced to preliminary status. And just as reference, the preliminary recognition status enables organizations to more quickly apply to become Medicare diabetes prevention program suppliers and DPP suppliers. And, we hope that this and other payment sources can again go back to promoting long-term sustainability that we had mentioned earlier. Oh, actually, if we could go back to the previous slide. Thank you. Additionally, from the organization, an optional field for social needs is going to be for a social needs assessment, information on participants, and that'll be included. In this version of the DPRP standards, data elements related to health-related social needs are included so that we can really all better understand the relationship between these needs and participant outcomes in the National DPP Lifestyle Change Program and identify ways to support participants in accessing and participating in the program. So again, this is an optional element in the standards, but it's also something that we're working in other ways and with our partners in our program and activities that we'll discuss later to assess and incorporate as we tailor this program to meet the needs of programs delivering this in tribal communities or serving American Indian and Alaskan participants. For participants, collecting the zip code is going to provide a more precise understanding of the geographic landscape of national DPP participation. And it allows for a deeper understanding of geographic areas of disparity to formulate program materials and provide technical assistance to organizations delivering the programs in these areas. Collecting disability status is going to involve a 6-item variable as recommended by the Office of Management and Budget, and will allow CDC to analyze participant data from a functional perspective to determine disparities between disabled and non-disabled population. Changes to race ethnicity collection consists of 2 additional options with an existing variable. So the revision is going to allow CDC to align with OMB and health equity best practices guidance that recommends collecting additional race ethnicity information from participants to create more accurate reports and a better understanding of populations being served. The new variables include Middle Eastern or North Africans, but there's also a write-in option, which I think is really pertinent to what we're talking about today. And so the intake form will have a write-in option. And this is of particular note for Native participants because it allows for participants to self-identify as American Indian and Alaska Native, even if they're not enrolled in a federally recognized tribe. And, we recognize and know that this is incredibly important. So we're glad that that's there and wanted to include that. And the delivery mode, we're redefining combination programs, which allows for a better understanding at CDC of, at a program level of organizations' approach to combination delivery, and distinguishing between live delivery and online delivery. Where we are now with the standards, the 2024 standards or the updates to the standards were posted on the Federal Register in December. And at the same time, a Dear Tribal Leader letter was sent to tribal leaders. And many of you here were probably received that letter. And a copy is also on the CDC website. That comment period is complete. And we're currently in the process of synthesizing the comments, and we'll repost on the Federal Register for another 30 days. And at this time, the proposed release date for the final standards, 2024 update to the standards, is in early May. And we plan on actively disseminating this to tribal programs and beyond. And one of the asks if you will, of our presentation today and ongoing into the future is how we can best disseminate, those standards and really do our best to help programs implement those standards, whatever is needed as far as technical assistance and support. Next slide. Next, we wanted to present our newly initiated work. By new, I mean over the last few years, 1 or 2 years, to culturally adapt the CDC Prevent T2 curriculum for American Indian and Alaska Native participants. As a quick note, the CDC Prevent T2 curriculum is the primary national DPP curriculum and not a separate program. And the curriculum was launched in 2016 and follows the year-long lifestyle change program. And it builds on the evidence base for relationships between diet, physical activity, and health. An updated curriculum was released in 2021, and some of the modifications included a focus on whole foods, engaging coaching practices and storytelling, a tailored approach for cohorts, graphics, and other tailoring to allow for cultural representation. The curriculum has 16 core modules, and some of the examples are listed here. And there are also 6 reinforcement modules to be selected from 10 options, which together fulfill the 22-week cohort over 12 months. Next slide. So parallel to these updates to the Prevent T2 curricula in general, we've long been hearing, and this is surely not unfamiliar to committee members, we've been hearing from partners and tribal leaders about the really critical need for an adapted curriculum for American Indian and Alaska Native participants to really make not just the curriculum, but the program overall relevant. For Native communities. So that was a really, we really took that very seriously, but it's also a daunting task, and we're committed to a deeper and respectful tailoring that aligns with what's supported by the science of the curriculum. And as we started this work, it was really important to establish a few key understandings. We cannot create a one-size-fits-all that doesn't honor the diversity among tribes and cultures. But we do want to create something that captures shared cultural strengths and values and important issues and topics, with room for more tailoring in at a deeper community and tribal level. And we know that it's not for CDC to do this work of cultural tailoring on our own. And our wish is to be respectful and to center on the real experience of Native participants. So we were committed and still remain committed to making this a co-created product and seeking guidance at every step for a curriculum that's relatable and also honoring an honest history and current experience. And this value and mindset and just kind of, approach has been something that's really guided us for our future work too, that we'll go over today. So to begin determining the elements that needed tailoring in the spring of 2022, we convened a group of 8 partners representing 5 areas, and they were a combination of tribal programs, area health boards, and tribal serving organizations from California, Great Plains, Great Lakes, Navajo Nation, Portland, and others. And a big thank you to everyone. We're incredibly grateful for this candid feedback in helping to start this work. And the convening partners, they were invited based on their experience with the national DPP, including serving as program coordinators or lifestyle coaches. Some established a national DPP lifestyle change program, their understanding of the Prevent T2 curriculum, and adapting their previous work in trying to adapt the curricula. I mean, had they tried to do this before because they saw it as a need? And we also wanted to include folks who had expressed a desire for a culturally relevant curriculum, and also people, and this is really important, who chose not to implement the National DPP Lifestyle Change Program due to lack of cultural tailoring. And as we said, the candor of why things don't work is really incredibly important as we direct our work. So we used a phased approach to identify elements of the Prevent T2 curriculum that should be adapted to really create a more engaging and culturally relevant content. And the phases were gathering information on the previous curriculum adaptations and research, developing key questions for partners, conducting the interviews to refine the questions, and then conducting the convening with these partners to discuss how to prevent the Prevent T2 curriculum. And from this really came a value-based and cross-cutting themes. And they really, thankfully, and probably predictably, really strongly aligned with feedback that we've heard over the years from partners and our own qualitative analysis of tribal programs implementing the National DPP Lifestyle Change Program. And feedback in the session provided areas of opportunity for each one of these themes, and you can see here the supporting evidence and quick wins and long-term recommendations associated with each area. Embedding American Indian Alaska Native cultural preferences, considering relevance, visual example, addressing food deserts, commodity foods, traditional foods, and representing urban and rural tribal environments. Strengthening lifestyle coaches. So, and we'll talk about this, how this is kind of fed into our current work. Establishing the ability for lifestyle coaches, recognizing their importance in cohorts, and really bringing everyone together and establishing the relationship between participants in the cohort, and engaging techniques and best practices. What really emerged also was instituting a whole family approach and including community and family, considering prediabetes and diabetes, the impact among youth, which is a big issue, and addressing the stigma of prediabetes and diabetes in communities, and connecting to resources. And this was really big because eligible participants currently in the National DPP Lifestyle Change Program, it's for 18 and older, but that is for counting the eligible participants to be reported for recognition. But the class overall and the cohorts overall, we really want it to be inclusive of the entire family, which we know is such an important aspect and cultural value of Native communities, having the intergenerational family tie. And also we saw a few programs who were instituting an approach like this already, and they had incredible retention as well. And last was incorporating formatting and delivery changes, which is, kind of flexibility in delivering the curriculum, considering, just sustainable weight loss, and incorporating teachings on mental, spiritual, physical health aspects of the curriculum. Next slide, please. In the next phase, in the beginning, which goes from 2022 and ongoing, we're working with a curriculum developer and also a Native-owned agency to take these themes and apply it to the Prevent T2 curriculum. And we conducted 3 sessions. So we went from this panel where we got the four themes into taking that and going into finer detail of reviewing each module. And we conducted 3 sessions of expert panels to review the curriculum for nutrition, physical activity, and behavior change in the modules in context of the relevance of cultural adaptation. And again, we had 13 longtime coaches and coordinators, each having over a decade of experience working in diabetes prevention in tribal communities, not just national DPP lifestyle change program. And we wanted to include all programs really working in diabetes for prevention in Native communities. And their diversity was really represented by geographic location, professional background, and varying stages of implementing the Prevent T2 curriculum. Again, it ranged from implementing it to knowing about it, but not implementing it because, of different cultural adaptation, barriers. So we organized the expert panelists and assigned each person to a core topic based on their expertise. And the experts were provided guidance that outlined which modules to review, as well as areas to consider providing direct feedback. And they were asked to review the curriculum through a lens of cultural relevancy and also based on their experience. Next slide. And from these incredibly informative sessions, they were really wonderful. We heard some key themes. One was really top of list was time constraints. Panelists voiced that the pace of the Prevent T2 curriculum felt sometimes rushed, and there often wasn't time to cover all of the material in one session, and just really navigating virtual content during in-person classes, such as playing videos, sometimes takes a lot of time away from the group, and especially if internet access is limited. And just also recognizing the need for that, peer support and discussion and the stories that everyone has to share. So the participants also stressed the importance of allowing program participants the time to share and bond, develop trust in the group, which really predicts success. And participants, their experience with participants really liking to discuss their challenges and getting group support. And again, these are things that really add to the group. And so with time that's needed for that kind of discussion, it felt like the overall time of the class was kind of short. We also heard the need for coaching training and facilitating skills, and new coaches needing better training and facilitation skills on how to navigate really tough conversations. And participants agreed that it really takes a good lifestyle coach to redirect the conversation to allow participants to discuss how they feel about the topic, and having a coach with a lot of passion really matters. And technology barriers, which I think, comes as no surprise to any of us. And the curriculum as it was, they felt relied heavily on internet connectivity and web links, which can kind of be confusing to navigate when there's limited internet access. Next slide. Thank you. Additional challenges that we saw, some of the recommendations were adapting the photos, names, and stories, giving the option to add community-specific cultural foods, physical activity examples and stories, and adapting physical activities to be more relevant to Native communities like safety, and then also rural areas with limited access to gyms, if there's a reference to that. And adapting nutrition-centered lessons to be mindful of barriers to accessing nutritious foods. Next slide. We also saw just the need to focus on strengths, adapting examples to meeting people where they are, and using judgment-free language, being mindful of the impacts of historical trauma and the current lived experience of Native people. And this is a really, really important issue and topic, and something that we're committed to incorporating, whether in the curriculum or also guides and prompts for coaches to be trained to deliver that or to access that, depending on their assessment of their particular cohort, to move beyond just changing pictures, names, and recipes. Inviting coaches to supplement the modules with community-specific foods, stories, activities, differentiating between commercial tobacco and sacred tobacco, and changing the layout to be, more printer friendly. Next slide. And just to speak, to just next steps, the team has begun to adapt the modules for field testing and selective active cohorts. And these insights have also been applied to the adaptation of another resource, CDC resource called New Beginnings, the discussion guide. And we've begun the process of identifying testimonial stories and really developing an overall look and feel with images, color palette, font, as well as like the deeper content that we talked about. And this feedback's really informed and aligned with other current work that that we'll go over. So on this slide, we heard from partners also, and again, this probably comes as no surprise, the need to use images and content relevant to American Indian and Alaska Native people. And the Division of Diabetes Translation worked with a Native-owned media firm to photograph images across 3 geographic regions, depicting regional cultural diversity across tribes. And we plan to use these images in our content and our curriculum and really beyond. The intention with the design, curriculum framework, and adaptations, they're really the first in demonstrating the shared intention of building a connectedness among the program with Native programs and communities, and serving American Indian and Alaska Native people. Next slide. So we're in early stages of additional work to meet the needs of tribal programs. And again, as we mentioned, we've seen our work really evolve from what we've done a few years ago with these talks with partners and these convenings, and what we've learned into really finding out what the deeper needs are. And that's really helped to shape and push our work, and will continue to do so. So some of the other programs, and work that we have ongoing is building on a pilot program that we mentioned, led by Choctaw Nation of Oklahoma. We're working with area health boards, 3 area health boards right now, in a shared and co-created roadmap of how to support and establishing and sustaining diabetes prevention networks with area tribes. And so we're really working with these health boards to hear their needs, their unique strengths and capacity, and the needs of their tribal partners who are delivering the program. And this really has the potential to provide support and assistance to tribal programs who are doing this incredible work. They're changing the trajectory of health for their participants. We hear that from the coaches who are delivering this program. They're really making a difference. And they have incredible motivating stories of participants really engaging and implementing these changes, not just for themselves, but for their families and community. But they just need the strength in numbers and also the support to gain that recognition, and some technical assistance. So, our work and our mission is to how we can work with area health boards to help with that. We're also working with training entities to expand the small but mighty existing group of master trainers, and also to expand the number of lifestyle coaches and who deliver to tribal programs. And we hope to include the culturally relevant recommendations into these trainings, and in the future create a network of ongoing support to help mitigate the impact of staff turnover, and the reality that everyone working in tribes, wears 20 hats or more, so, and the staff turnover is something that we've heard a lot of. And last, we conducted a needs assessment with current CDC recognized programs for technical assistance and support to build their capacity to establish and sustain the national DPP lifestyle intervention. And this needs assessment will be shaped into recommendations and then an ongoing strategic plan for our division and everything, kind of all of our work moving forward. Next slide, please. So in summary, these are some of the things that we shared, the shared history between SDPI and the National DPP, an overview of the National DPP and the Diabetes Prevention Recognition Program, DPRP, updates to the 2024 standards, an overview of the cultural tailoring of the curriculum, and also other programs, activities that we're working on to help to tailor our programs. And again, with that definition of health equity, how do we not just deliver more of the same, but also deliver what's needed? And first and foremost, always really trying to access what people need and talking to our partners and going from there. Next slide. We are incredibly grateful for your valuable time and guidance, and specifically, we'd love to hear from the honorable committee members on recommendation on soliciting input from the National DPP delivery organizations serving tribes about their challenges and successes, as well as recommendations to strengthen partnerships or other efforts. Anything that you can suggest. Next slide, please. And in closing, I would like to again express our deep gratitude for the privilege of sharing the work of CDC's Division of Diabetes Translations work today. And as stated earlier, we're really committed to serving communities in diabetes prevention and honoring the federal trust responsibility. And we want the guidance, your guidance, to shape our ongoing work. And as always, your candor is deeply appreciated and very welcome. So with that, thank you. And we can open it up for questions and comments, I think.
Thank you, Ms. Muthuswamy, and for your presentation. TAC members, I'll welcome your feedback. If you have additional questions or comments regarding CDC's National Diabetes Prevention Program, we encourage you to share those thoughts. The floor is yours, and we look forward to your valuable contribution. Is there anyone on the line that has a comment or question? Be sure and raise your hand, do your little hand sign if you want to comment. Okay, anyone here at the table have any questions or comments? Okay, Sharon.
Sharon Stanfield, Rep at Large. Well, that was a great presentation. Thank you. I commend you on the work your office has done, your commitment to tribal nations. I love the marketing materials and the work you've done, the work you've done with the tribes. You have some, those.
We love your picture on one of the slides as well. It's great to see you again and talk.
Not that part. But the 12 tribal nations and urban, I saw Nara up there. You got some real experts helping you, and you should be proud of your accomplishments. We do appreciate every few years, I think it's every 3 years now, that you go back and you look at your metrics, your requirements, and the things that will make the program sustainable for the country. We do appreciate that. And there's still work to do, always. There is work to do, but just want to thank you for all that you've done for Indian country. And if I could make a few comments. The first has to do with the SDPI. The reason the SDPI has been so successful is because the tribes have been allowed to do it their way. And we found that out real early. And the funding wasn't contingent on whether or not the tribes were all doing it the same, if the data added up. We really knew that in order to make this program successful, and it's a quarter of a century, if you can believe it, over 25 years now, that SDPI has really become the most effective public health program in the nation. We know childhood immunizations, and in your program, obviously you stated it's number one in the nation as well. But the SDPI was done by the tribes. We were the leaders of doing it, and we learned a lot of lessons that we've shared, and we probably shared those with you. One of the things I really want to point out is that the key to this whole program is the lifestyle coach. And so I appreciate the trainings that you're going to be starting up, and I understand that there'll be hopefully we'll have consultation and we can talk about some funding perhaps to each area so we can have a master trainer that will be able to work with our tribes so that we can have strong lifestyle coaches in our communities. But I wanted to touch on just a few things. And one is the preliminary status that the tribes were grandfathered into. Whereas that's been great, you've noticed that not even 25% of the tribes that have SDPI are in this program. And one of the reasons I think is because of the difficulty in the data, as you're aware, all the requirements of the cohorts, how big the groups have to be. We have some very small tribes. So if you have to maintain a certain number of people to come for 6 months and they can't miss, or you got to make it up, you need a pretty decent sized staff. You need your coaches to be trained. You need to be able to do a lot of the things that you're incorporating now. And so from 2019 to 2021, great strides have been made. However, really what should happen in true partnership and acknowledging the work of the SDPI is that these nations should be grandfathered into full recognition. And one of the reasons for that isn't just the respect of these programs and the honoring of the work that's been done here. It's also for the fact we can't get paid. I know in Oregon we can be paid with preliminary status, but I don't know if across the country all of these nations and programs can be paid for this work. And so in order to run programs, let's face it, you have to be able to have funding. Everybody needs to be able to have a staff person to run this. So I did my homework before I came to this meeting, and I spoke with some tribes in the Northwest. And one of the most successful programs is NARA Northwest, NARA, our urban site. They had to, during COVID, due to the negative impact of COVID, they had to go to a complete tele situation, whereas a lot of tribes had to shut down their programs. And in doing this, they had to use a lot of funds to be able to get iPads and all the things you need to do to be able to keep up this program. The lifestyle coaches had to transition, do things entirely different. They begged and borrowed from other programs just to be able to have staff to be able to help, because a lifestyle coach has to hold the hand sometimes of the participant and their family for a very long time for these lifestyle changes. These are mental health issues. These are social determinants of health issues, food issues. This is a very, very intensive program that lasts a year. So the NARA was able to make this transition, but in doing so, because they don't even have one full-time person, they had to piece it together. They gave me an example of just the data. They said that for 31 participants over the course of 6 months, they had to, a spreadsheet was 520 rows. It was 31 or 28 columns deep. And it took them hours upon hours upon hours with errors being kicked back from the spreadsheet. So they ended up purchasing a program that would help them because they know data is important. We all know data is important. So I think when we really get into the nitty gritty of how this program works, we need to eliminate as many barriers as we can. Data, get more lifestyle coaches into the tribes, let the tribes run their program as you're showing, incorporate traditional foods and events that we do. And a lifestyle change isn't about going to an event. It's about what you do all the time in your life. It's connecting spiritually. It's all of these things. So I just want to, in closing, say that really appreciate the work you guys have done, but we need to take a much deeper look. And I know you said May is the date that the new recommendations are going into effect, but we need another consultation. We need to look at cohort size. We need to look at whether the data can't just be what we're already submitting for SDPI anyway, and how to eliminate some of these barriers, especially with the status so that these tribes can be paid for this program. So I want to thank you again, and thank you for hearing my comments, and just really encourage you to keep working with us, because this program is changing lives, as SDPI has proven to change lives. So thank you.
Thank you. If I could just say something, I know we're running out of time and I want to hear everyone's, but I really deeply want to thank you, Dr. Simple, for your comments today. And also, it's nice to see you again. And Ms. Parker also, like we saw each other at TLDC, and it's just so wonderful to continue this work. And this is exactly what we want to hear. And we're incredibly grateful and privileged to have your candid feedback and partnership in this. And a lot of things that you discussed today, the need for master trainers and lifestyle coaches, we're really trying to address, but also stronger commitment to letting the tailoring of these programs really fit what communities and programs need, and taking that as from the incredible success of the SDPI programs, and incorporating traditional foods, the whole family approach, the events, but the data submission also is something that we're really taking another look at. And as far as extending the full recognition, I hear that, and definitely we will take that back. But I'd love to ask you, and I know my colleague Beth Ely would love to ask you a question as well, so I'm going to turn it over to her. But I'd love to ask, and maybe if it's not on today's call because we only have a few minutes, but if we can work together, if we can contact you and Nara, in the future, because we have so many points of feedback in all the projects that we're going in, but we really want to have these focused discussions of the incredible work that tribes in Oregon have done. I was a project officer in GWIC for Yellowhawk and others, and so in extending full recognition, how can we also, or getting your feedback and everyone else's feedback, how can we really help support the sustainability of full recognition? And the reimbursement piece is definitely a part of it that needs to be tackled. And but we'd love to continue that discussion. And thank you so much. And if it's okay with the facilitators, can I turn it over to Beth to ask a question, or should we take other questions?
Are there any other questions at the table?
I should probably ask that first.
Okay. If not, yes, go ahead.
Beth, do you want to?
Yeah, hi, thanks. Hi, Sharon. That was really great for us to hear. I work with the data component. So when you talk about the data submission, that's me. And I guess, and we probably don't have enough time now. I'd love to actually talk with you though, at some point about, because you did acknowledge the importance of data. What would make the process easier? I think, and again, not something to get into now because there's not time, but I would really love to hear from you and hear what you think that could look like. The only other thing I want to say, and I don't know how much consolation this is, I don't believe Kavitha mentioned this, is with the new standards, we are proposing indefinite recognition. So once an organization achieves full recognition, they've got it forever. And we're doing that because we feel that if you achieve that full recognition, you've met the requirements, you've checked that box off, we know you can do this, and now let's take the pressure off of you. So you have it permanently, and all we ask is that you continue to run your program the way you need to run it. So hopefully that at least will help relieve a little bit of the pressure.
And on this last slide, and hopefully, obviously this, everyone has the slides and we'll have the recordings. That's my email there, and also the our websites, and also we have a customer service center that that's really incredible. So please, anyone in the committee today or others, or like please send us those comments and feedback, because we really do want to engage. This is just one part of how we're trying to reach out and connect. This is incredible. Thank you. Anyone else?
Any other questions or comments? Okay, go ahead.
This is Sharon Stanfield. I could make another comment. I think if we could work with CMS, that we would be able to, it's just Medicaid, but at least we could have one payer, right? Be able to recognize everybody who is in pending status now. Again, I want to emphasize only 25% of our tribes that have SDPI even are attempting this. I think once COVID hit and things, it was difficult for tribes to keep up with the data. So therefore they just dropped out of the recognition process. I know of several tribes that did that. So I think we're trying to move the needle the other direction, is to get tribes to want to be recognized. And yes, that's a great quality. We're into quality of our programs. We're into data. We're into all of that. But we really want to make sure that we don't have more barriers in doing that. So that's why I think working with CMS is one aspect. Love to talk about the data. Love to talk about some of the systems that the tribes have adopted to be able to make this data more streamlined and make it easier on themselves. But to think it would take a whole week to do that kind of data entry, that's just a lot of work. So thank you.
And thanks for mentioning that even if tribes, tribal programs aren't pursuing CDC recognition, they're still doing amazing work in preventing diabetes, and how do we get them to want to pursue their recognition, or pursue recognition through this and participate in this program. Thank you for that.
Okay, thank you, Ms. Muthuswamy, and thank you for the wonderful presentation. So we are going to be moving on. We actually have another break from 2:30 to 2:45, but let me just mention this right quick. You were given these sheets of paper for TAC meeting suggestions. So if you would fill that out, and there is a suggestion box out the door, I think on the table out here, and if you would put that in that box during break, then that would help maybe plan the next meeting, agenda items. So we'd appreciate it if you do that. Thank you. And we will reconvene back at 2:45, and that will be, at that time, we'll be hearing a presentation from the Office on Smoking and Health Engagements, Current and Future Initiatives. So we will be right back.